All right, then without further ado, let's go. So salivary gland. We're going to go over certainly some normal salivary gland histology and some non-neoplastic entities. We'll go over the FNA biopsy approach to neoplasms. And the bulk of this talk is going to be sort of going over the histology of both the benign as well as the malignant neoplasms. So when we're talking about types of glands, we will talk about the three major salivary glands being the parotid, the submandibular, and the sublingual, which are composed variably of serous and or mucinous cells. The serous cells being sort of the purple ones that contain the predigestive enzyme granules, the zymogen granules. The mucinous, of course, being the paler ones that contain mucin, for more of a lubricative function. But as you know, there are minor salivary glands all over the upper aerodigestive tract, tongue, palate, lips, buccal mucosa, all of which have varying sort of degrees of serous and mucinous acini. So just as a review on low power, your parotid gland is essentially entirely serous. Its entire function is digestive enzymes. So all of your cells are going to be this granular purple. The submandibular, as well as some minor glands, are mixed seromucinous. So you're going to see these serous so-called demilunes, like half moons, with the remaining portion being mucinous. And then there are some minor glands, as well as the sublingual gland, that's pretty much mostly or entirely mucinous. So again, you can see mostly just the watery cytoplasmic contents with very few to none of the purple digestive enzymes. So that's how we sort of can sometimes know where we are in the salivary gland anatomy. In terms of some more of the benign things we see, one of the more common things is a mucocele, which is essentially a pseudocystic reaction to extravasated mucin, meaning, when the mucin leaks out of the glands and or ducts, it is sort of leaks out into this pool, and the macrophages and fibroblasts of the body attempt to contain it. And so what you see are actually these macrophages, which are termed mucophages, right? So the macrophages that eat the mucin are the mucophages. And then this sort of wall of fibrous tissue and inflammation. It's not lined by a true epithelial lining, hence a pseudocyst. But we see these mucoceles, of course, as fluctuant lesions in the lip, the tongue, the mouth, where people could potentially be biting and leaking mucin out, etc. But as you know, these things can grow to larger sizes and become so-called ranula, right, which are on the floor of the mouth, involving the larger sublingual gland, or of course a plunging ranula that plunges down into the neck and is visible underneath the skin, all of which of course comes from the lovely neck protrusion of the frog, rana, so hence ranula. Another mass-forming lesion that is not a tumor is, of course, a stone or a sialolith, which epidemiologically is thought to be most common in the submandibular, but can, of course, be present in any duct. Histologically, it looks as this sort of concentrically lamellated circular structure that is actually residing within a duct, right? So we can see the epithelial lining here of the duct and the stone in it. It's thought to sort of start as a small nidus and then sort of collect and enlarge. And of course, as it plugs the duct, you can get cystic dilation downstream of it, with resulting sort of atrophic or dilated changes to the remaining salivary gland. Okay, so sometimes you guys will send us lip biopsies for Sjogren's syndrome. And, fortunately or unfortunately, in the patients that have overt Sjogren's syndrome, we don't really see a biopsy. And it's mostly the patients who have sort of an indeterminate, non-diagnostic, vague picture that we get the biopsy. And often the biopsy is also equally vague, non-diagnostic. But what we're looking for is essentially foci of inflammation within the salivary gland, a focus being essentially 50 or more lymphocytes. And we will score how many foci are really only in the most inflamed 4 millimeter squared field, which is a relatively small field, a 10x objective. So we're not scoring the entire tissue. We want to keep it consistent, right? Because sometimes we may see multiple salivary lobules, sometimes very few. So we really only want to score the most inflamed field. with the grading system seen below, described by our own former, Langerman and Taxi. So what we're looking for is essentially a blue area, right? This blue area composed of lymphocytes and plasma cells. In this case, it's sort of surrounding a duct and pushing into the adjacent stroma. But as long as you see this field containing one of these lymphoid foci, your focus score is 1, right? Each focus in that field gets a score of 1. And therefore, one focus results in a grade of 3, which is actually thought to be grades, quote unquote, 3 and 4 are thought to be predictive of Sjogren's. With as long as you have a focus, you're probably pretty good to call it Sjogren's, if that makes any sense. All right. However, you can get a chronic inflammation or atrophy or injury not in the setting of an autoimmune disease, right? You can get chronic sialadenitis in the setting of repeat injury. You can certainly get atrophic changes in the setting of chemoradiation, which we see a lot in our head and neck cancer patients. So atrophy of salivary gland looks as you can see on the bottom, sort of fatty replacement of the gland and relative shrinking of the acinar functional units. You can also get intervening sort of pink fibrosis. But as you can kind of appreciate, your ductal lobular architecture is retained. So you still have this central duct, you still have these peripherally located acini, and they sort of retain this tree branch-like pattern. But essentially, the acini sort of look, as I would say, less juicy, right? They look kind of sad and shrunken. Sometimes in a severe atrophy and chemoradiation state, you get frank sialometaplasia. Sialo, of course, meaning salivary, and metaplasia being change in cell type from one to another. And so what this is change in your normal glandular salivary cell type to a squamous or squamoid type of epithelium. So here on the bottom, you can see these cells are now more elongated with nucleoli with some grungy intraluminal material, but very focally, you see retention of the mucinous cells in the background that makes you know that you are truly in a salivary gland site rather than, for example, the differential diagnosis histologically might be these would be islands of residual squamous cell carcinoma because of the squamoid morphology of the cells. But when these foci retain the ductal lobular architecture, et cetera, this is sialometaplasia. Occasionally, it's this isolated ulcerative lesion on the palate, but more frequently, we just see it kind of patchily in the setting of chemoradiation. Okay, so there are some lesions where they sort of walk the line between are they non-neoplastic or neoplastic. And there's this one entity I'll briefly mention called sclerosing polycystic adenosis, or adenoma if you believe it's a tumor, which is a benign lesion generally found in the parotid of adults. And so it sort of resembles conceptually fibrocystic breast disease, where you have these kind of variable small microcysts, larger dilated cysts, and then these solid proliferations. That was thought to be a reactive change, but recently some clonal anomalies in various P10 and related genes have been found. Therefore, it's thought to potentially actually be a tumor. It's regardless of whether it's a tumor or not, it's very, very rare. But just know that this sclerosing polycystic adenosis or adenoma is either a reactive change or a benign tumor. All right, so moving on now to the actual tumors. As we know, benign tumors are much more frequent than malignant ones, and the most common location of everything is going to be in the parotid. However, you can get salivary type tumors in any salivary gland containing organ of the upper aerodigestive tract, all the way, in the mouth down into the larynx and trachea, where we can see things like adenoid cystic, et cetera. So salivary type tumors can occur in any salivary gland site in the head and neck. The site with the highest rate of malignancy is going to be in the sublingual gland. But the malignancies in general, the salivary carcinomas, are quite rare, only 6% of all head and neck cancers. Thinking epidemiologically, of course, the most common tumor is pleomorphic adenoma. The second most common benign tumor is Wharton. The most common malignant tumor is mucoep, followed by adenoid cystic. So when we have a mass-forming lesion of the salivary gland, FNA biopsy is our preferred screening tool. Occasionally, we do see core biopsies, but generally they are FNA'd. And so just like when we talked about with the thyroid gland, there's the Bethesda system for categorizing the FNA biopsy. There's now the Milan system for categorizing salivary gland biopsy. And that ranges anywhere similarly from 1 to 6, 1 being non-diagnostic, 6 being frankly malignant, and everything in between. So we have non-neoplastic, atypia, I can't really tell if it's a tumor or not. And then we have definitely tumor, being either benign, again, or suspicious for malignant. And so what happens, you have estimated risks of malignancy in these patients depending on what category your Milan ends up being. Mostly if it's non-diagnostic or non-neoplastic, these may either require, some kind of follow-up or repeat FNA, whereas your definite neoplasms will generally require surgery. And the extent of surgery, of course, will depend on the reported or expected grade of the tumor. So here's some examples of what we might see. So for non-diagnostic, you might see something like just cyst contents. Here, I'm showing you just some foamy macrophages. You can see this very pale vacuolated cytoplasm in a sort of grungy background. There's no mucin, there's no other structures that might indicate what's going on here. This is just the middle of a cyst. So it could be the middle of a cystic tumor, but we don't see any epithelial cells, so we're not sure. So this is essentially non-diagnostic. If you just poke a normal salivary unit and don't actually get the lesion, this is also non-diagnostic. So this is what normal salivary acinar cells look like on FNA, sort of this grape-like cluster on a central sort of duct core. And then on the right, we have chronic sialadenitis, which is these clusters of glandular cells here with inflammation in the background. If the entire gland is diffusely involved, and this is what you see, that's probably enough. But if there is a mass-forming lesion and this is all you see, theoretically, there might still be something hiding. And then the tumors. And so, sometimes on FNA for salivary, you can say, oh yeah, that's definitely a pleomorphic adenoma, done. But sometimes the morphologic features are overlapping and a descriptive diagnosis may be made, such as, I feel like this is a neoplasm, but I can't really put it in a particular bucket. And that's this kind of column on the left. So the bottom left ended up being a pleomorphic adenoma, and the top left is an adenoid cystic carcinoma. And you can see that there are some similarities in terms of these sort of monomorphic, very blue cells in the background with round to oval nuclei and sort of fine chromatin. And then this eosinophilic stromal material. And subtly in the pleomorphic adenoma, the eosinophilic stromal material is a little more sort of fibrillary, like it's sort of poking out. Whereas in the adenoid cystic, it's this so-called gumball, right, with a very, very round rim. And so if the characteristics of the stroma or the cells are not clear, one might say, all right, this is a basaloid salivary gland neoplasm, but I can't tell pleomorphic adenoma versus adenoid cystic. In this case, the characteristics of the stroma are such that we can favor one over the other. On the right, I'm showing you an example of our other two common tumors, Wharton on the top left and mucoep on the bottom right. And the findings here are in Wharton tumor, as you'll see on the histology, we'll be looking for oncocytic cells, oncocytic meaning sort of abundant pink cytoplasm with sort of oval to large round nuclei. And in the background, these many, many, many small lymphocytes that really don't have any cytoplasm. They're kind of floating. That's good for Wharton tumor. And then on the bottom right, mucoep. So you might ask, why this is a mucoep? Well, mucoep is one of the very few to only salivary gland type of tumor that truly produces mucin in the neoplastic cells. And so what you see here is a nice signet ring, sort of goblety mucin cell. You maybe see some more intracytoplasmic mucin here. And so when you have a neoplastic population, with both intracytoplasmic mucin as well as, oops, where did my mouse go? I lost it. As well as some background stromal mucin spread out on the slide. Those features would be good for a muco-ep. There it is. Okay. So, all right. So these are our 4 examples of neoplasms that were able to be diagnosed on FNA. Okay. So once we have a salivary gland neoplasm, what are we going to do? So we certainly want to determine if it's a primary parotid or a metastasis to the parotid, and that's not always obvious, but it can sometimes be determined. If it's something like a squamous cell carcinoma or a melanoma, those are essentially almost uniformly going to be metastases, squamous from skin and melanoma of scalp and melanoma as well. So the treatment of these will generally depend on the overall status of disease, but neck dissections could be performed. If this is a primary parotid neoplasm and it's benign, like a PA, you're going to resect it with negative margins and observe. If it's a non-conclusive or low-grade malignancy, again, resection with clear margins and observations is generally treatment. And so we pathologically realize that for a low-grade salivary carcinoma, you're probably not going to be doing a neck dissection. Whereas for a high-grade salivary carcinoma, you probably will be doing a neck dissection, potentially followed by some other kind of adjuvant treatment. So sometimes on biopsy, we don't really stick our neck out and commit between benign and low-grade malignant because the treatment isn't going to change. And the histologic features or cytologic features can be very overlapping. And unless you see the margin of the tumor being infiltrative, which you can't on an FNA biopsy, right? Sometimes you can't really make the differential diagnosis between benign and low-grade malignant. So we maybe just say low-grade neoplasm, or conversely, high-grade carcinoma, because that's where the clinical decision-making branch point will occur. If I'm incorrect, please let me know, because we like to know how the treatment algorithms change so that we can better provide diagnoses. But up until now, this is sort of how we've been functioning. Once the gland is out on the table, what do we as pathologists do? So again, confirm the tumor type, primary versus metastatic, subtype the tumor as best we can, because now we have of course, the entire tissue. Confirm the grade. So sometimes grading in salivary gland can be challenging, but there are certain high-grade features that we look for, such as perineural invasion, lymphovascular invasion, necrosis, et cetera, that'll push something into a high versus a low grade. Certainly we'll comment on margins and provide your TNM tumor stage. So, there are a lot of salivary tumors, and they can be quite daunting for diagnosis in, unfamiliar settings. And so this table is basically charting out how I think about these. So there are benign tumors. There are benign tumors that have malignant counterparts like PA, carcinoma X PA, right? Basal cell adenoma, basal cell adenocarcinoma, et cetera, et cetera. Then there are tumors on the right that are really only malignant, right? And don't have a benign counterpart. So if something matches this morphology, it's already a malignancy. You just need to decide whether it's low grade or high grade. You meaning me, right? And then we like to look at the number of cell types in the tumor. One of the most helpful things for diagnosis of salivary is, does it produce a single histologic cell type? Does it produce both of the salivary gland cell types, classically being the epithelial and the myoepithelial cells, right? The myoepithelial cells being the contractile cells around the acini or around the ducts, right? So both of these cell types can come into play in neoplasms as well. And we also sometimes think about molecular. So even though molecular isn't very frequently used for diagnosis of salivary, it can certainly help in equivocal cases. Once you make a diagnosis of a carcinoma, of course, as I said, grading will become important. Any of these tumors can essentially be low or high grade, with the rare exception of some that are essentially uniformly high grade, such as invasive salivary duct. All right, but we'll go through these in more detail. So my approach to salivary tumors histologically is to examine the border being circumscribed or infiltrative. So a circumscribed border can be both a benign malignancy, a benign tumor, benign adenoma, as well as a very, very low grade malignancy. However, infiltration is certainly the best indicator of malignancy, and sometimes it can be subtle. As I said, we examine the number of cell types being monomorphic one type, either epithelial or myoepithelial, and then biphasic being both epithelial and myoepithelial. We then examine the morphologic pattern, which can be sort of subtyped into sort of basaloid, cribiform, tubular, cystic, secretory, mucinous, solid, nested, clear, spindled, right? So all of these pattern-based approach to diagnosis will be our guide, and we selectively use immunohistochemistry or genetics to come up with a final diagnosis. So let's start with our benign tumors with malignant counterparts. Again, breaking them down into the number of cell types. So for benign tumors with malignant counterparts with 2 cell types, right, we'd be looking for pleomorphic adenoma plus or minus carcinoma X, and then basal cell adenoma, basal cell adenocarcinoma. The monomorphic tumors are listed here, and we'll go through them. So of course, starting with PA are most common. So grossly, this has a very clean, crisp edge on cut surface, right? So you're looking at a pathologist cut through the center of the tumor, often resembling cartilage, because as we know, the stroma of a pleomorphic adenoma is chondroid chondromyxoid. So this glistening white cartilaginous look is quite characteristic of PA. Pleomorphic adenoma, why pleomorphic? So it's not uniformly pleomorphic in terms of cytologic pleomorphism, meaning the nuclei aren't large, irregular, hyperchromatic, angulated. It is polymorphous or heterogeneous in terms of its architecture. So it is not pleomorphic nuclei, but it is polymorphous or heterogeneous architecture. All right, and what do we see in that heterogeneous architecture? We see characteristically epithelial and myoepithelial cells forming these bilayered ducts. And I think you can see quite nicely this inner epithelial cell layer, this outer myoepithelial cell layer. And these ducts are embedded in this very pale blue myxoid stroma. Here on the left, you see more of a cartilaginous type of stroma that's a little bit more almost pale white or very, very pale blue. The cells, these little single cells embedded in the stroma are the myoepithelial cell component as well. Sometimes you can have myoepithelial cell component that is quite rich. It can be spindled, it can be plasmacytoid with eccentrically placed nuclei, or they can be, again, these very small inconspicuous ones. So hence the heterogeneity, right, of the pleomorphic adenoma. Here's an example of cartilage on the left, a cartilaginous tumor. And here on the right is the chondroid stroma of a pleomorphic adenoma. So, all things being said, if you see something that looks like cartilage in the salivary gland, chances are you're just dealing with the chondroid component of a PA rather than, a chondroma or something like that. Tyrosine crystals may be present in the stroma, which is very unique. Here on the right, you see sort of this lobulated tumor with, again, this very pale stroma and normal salivary tissue on the left. Okay, so what can a PA do? It can, of course, recur after incomplete excision as these sort of multiple small nodules. It can metastasize or travel outside of its native site in a histologically benign fashion, sometimes called benign metastasizing PA. But more oftenly, it will truly transform to a high-grade malignant carcinoma, carcinoma X, with infiltrative destructive behavior. But it usually starts as an atypia within the tubules of the pre-existing pleomorphic adenoma as this sort of in situ component, and then it invades. And once it invades, it is thought to be an aggressive high-grade carcinoma. So here's histologic examples of those. One, the recurrent PA with these very small, I like to call them sort of buckshot nodules within the parenchyma. And then actually carcinoma X. So Carcinoma X is thought to be 12% of salivary malignancies and 6% of PAs. By definition, it's either a malignant tumor with evidence of an adjacent hyalinized, sort of burnt out benign PA, or a malignancy arising in the same spot as a prior benign PA that has been previously excised. Here's what it looks like. So here's the transformative component, right? Where you still see the double layered epithelial and myoepithelial cells highlighted by immunohistochemistry. But what you start to notice in the epithelial cells are numerous mitoses, cellular atypia, meaning enlargement, and prominent nucleoli. So this is the beginning. This is how it starts. And then it invades, right? And so here on the bottom right is your hyalinized nodule. And here on the left are your tongues of invasive tumor that percolate into our normal parotid gland. And this is characteristically what we see in carcinoma X, this picture right here of hyalinization of nodule with invasion. The invasive carcinoma component, as seen here on the top left, can essentially be of any of the histologic subtypes of carcinoma. So it can be salivary duct, it can be squamous, it can be myoepithelial. It doesn't have to be a particular histologic subtype. It can be any of these salivary gland carcinomatous subtypes. But regardless, it all comes out of this pre-existing pleomorphic adenoma on the bottom right. Here's another example of that, that atypical in situ component with an atypical mitosis, et cetera. I won't belabor that. We've already discussed it. Okay, so some things that pathologists look for in PAs are, some metaplastic changes, et cetera, that are not really indicative of carcinoma. I won't belabor that with you guys. Okay. So genetics of PAs are both involving the PLAG1, pleomorphic adenoma gene 1 rearrangements, as well as HMGA2, high mobility group, transcription factor. Both of these are characteristic of pleomorphic adenomas. All right, what if you have a tumor composed entirely of myoepithelial cells? This is thought to be a myoepithelioma. This is quite rare in the salivary gland. Generally, you can find a duct or so here and there, and it's thought, therefore, that they are probably just myoepithelial-rich pleomorphic adenomas. However, true myoepithelial carcinomas can be found in the salivary glands, and these are defined as, of course, single cell type myoepithelial cells with infiltrative destructive growth. These can be transformed from a PA, as I said, or they can be de novo. If they're transformed from a PA, they can retain that PLAG gene rearrangement. Sometimes you can also see EWSR gene rearrangements in these, especially if they demonstrate clear cell morphology. So what do they look like? So you can see these very large, sort of on the left, lobules of lots of cells with this central pale area, which is usually central necrosis. These cells are these very kind of linear strands and cords of cells within this pale mucinous stroma. Remember that the myoepithelial cells of the pleomorphic adenoma were also embedded in this myxoid stroma, as are the myoepithelial cells of the myoepithelial carcinoma, right? But the nuclei are much more enlarged and atypical and wrinkled, and that's how we know this is a malignancy as opposed to a benign entity, yes? And just remember that the myoepithelial cells are the ones that actually produce this stromal mucin, and they sort of then embed themselves in it. So this myxoid background is very common to myoepithelial cells, here showing lobulated growth, as I said, central necrosis, and invasion. Okay, so moving on to our second most common now benign tumor is Wharton tumor. So we know that these can be multifocal and bilateral, especially in smokers, which makes you think, are these truly neoplasms, or is this just a reactive change if these can be multifocal? Like, how common is it to have the same tumor pop up more than one place? Well, in fact, it's been shown that Wharton tumors may actually be non-clonal. Therefore, they may actually not be tumors. They may be non-neoplastic, but whatever. What we know about them is that they can be solid or cystic, they can fluctuate in size, and they can certainly uptake technetium in our PET scans, right? And so people get PET scans who, they get a lung cancer, they're a smoker, they get a PET scan, and then something pops up in their parotid, and it's probably a Wharton, right? And so this is not an uncommon clinical picture of an incidental Wharton tumor in a patient with some other cancer because it popped up on PET. What do they look like? So there are these well-circumscribed lesions. You can see on low power, very, very blue. Well, the blue is that characteristic lymphoid stroma of Warthin, and the pink are these oncocytic cells that are forming nests and cysts. And inside the cyst, you can see I'm pointing out here this very grungy kind of material. These are what fluctuates and causes size change in Warthin tumor. So the characteristic oncocytic epithelium, what is that? So as you may remember, oncocyte basically means a swollen cell. And so these cells are filled with cytoplasmic mitochondria, as seen on the left here. So that little black thing is the nucleus. All of these little worms are the mitochondria. And that imparts this eosinophilic color and granular quality. And this rich, energetically rich cell may also account for the PET avidity of these tumors. So that's characteristically Warthin. Oh, let's not forget the lymphoid stroma, right? The inflammation in lymphoid-rich areas can also be PET avid. So probably both of these things contribute to the glucose uptake in the PET. Okay. All right. So how is oncocytoma different from Warthin tumor? They both contain oncocytic cells. So basically the lack of lymphoid stroma, the lack of a cystic architecture, and the presence of a more solid two trabecular architecture. So here's what an oncocytoma looks like instead. You see basically these solid nests and cords of still oncocytic, very eosinophilic pink cells with large nuclei and prominent nucleoli, but again, no lymphoid stroma, no cystic change. These tend to happen in elderly patients, sometimes sometimes in the setting of kind of oncocytic metaplasia or oncocytosis. So this is an example of an older patient's salivary gland. You can see has a nodule here, a nodule here, a little guy here, a little guy here, all of these oncocytic rich cells. So these are thought to be metaplastic changes. Again, change from a serous or a mucinous type to an oncocytic type of cell. And sometimes these little oncocytic nodules grow and expand into a larger dominant oncocytoma. Okay. So oncocytic carcinoma is differentiated, of course, from oncocytoma by infiltration, right? So you're going to see this repeated over and over again. Sometimes in a low-grade malignancy, one of your only ways to differentiate low-grade malignant from benign is that infiltrative growth. And so here's an example of a lobulated yet infiltrative growth pattern in a low-grade oncocytic carcinoma. You can see that on one edge, the border is circumscribed, but on the other, it sends these tongues out into the remaining parotid with some pink fibrous bands. That's invasive, okay? There is random endocrine atypia occasionally that we see in oncocytic, or I guess random oncocytic atypia with these very, very large cells. That is not necessarily a sign of a high-grade malignancy. However, what is a sign of a high-grade malignancy is increased mitoses, atypical mitoses, central necrosis, significant pleomorphism. All right, so this is an example of a high-grade oncocytic carcinoma. You can see the cells retain their granular cytoplasm and some features of oncocytes, therefore high-grade oncocytic carcinoma. Okay. Again, if anybody has questions or comments, please shout out or type anything in the chat. Otherwise, I'm just going to move on. All right, so basal cell adenoma is our next type of tumor that has a benign and a malignant counterpart. So these are rare, but mostly seen in the parotid. Again, they're composed of both epithelial and a myoepithelial cell component, but sometimes you can't really pick this out on H&E. Sometimes we need immunostains, excuse me, to differentiate. What's characteristic of these is, as I'll show you on the next slide, peripheral palisading with pink stroma. Genetically, these have beta-catenin mutations, so CTNNB1, and sometimes they have mutations in the CYLD gene, the cylindroma gene. So I'll show you a picture of the familial dermal cylindroma or the turban tumor. But these basal cell adenomas can resemble those tumors histologically as well. So what do they look like? Again, the benign ones are going to have a well-circumscribed border, and they are very blue and very cellular. So remember that when you have an FNA diagnosis of a basaloid, or blue salivary gland neoplasm, basal cell tumors are on that differential diagnosis as well. What we see on higher power are these large nests with, as I'm pointing out here, peripheral palisading. So palisading, right, just meaning these are sort of lining up like a picket fence. The central cells are a little more haphazardly organized, but what the central cells do is they secrete this very eosinophilic sort of globular hyalinized basement membrane material. So these eosinophilic globules are very characteristic of basal cell adenoma. You can see here that some of them actually show aberrant nuclear beta-catenin expression in some of the peripheral palisading cells, which is reflective of potentially a beta-catenin mutation in some of these tumors. Basal cell adenocarcinoma, of course, is differentiated by invasion, right? Infiltrative growth. Here's an example of that, a patient with familial dermal cylindroma, so turban tumor, so-called, due to loss of heterozygosity of the CYLD gene. So same gene implicated in these tumors is also present in the salivary basal cell neoplasms as well. What you see is these similar large blue nests, sometimes with a almost jigsaw puzzle rearrangement where the nests are kind of matching each other up, right? You can see here, there's actually a nice example of the contours being matched like a jigsaw puzzle. But what you see on low power, again, is not a clear border, but you see this tongue-like lobulated infiltration into normal. And so that's indicative of invasion. This is malignant. This can still be a low-grade malignancy if otherwise the cytologic features are bland, where in this case they are. Again, we still see that peripheral palisading with this jigsaw puzzle or contoured arrangement. We still see this hyalinized eosinophilic basement membrane material, and we don't see any other high-grade features, necrosis, mitosis, et cetera. So this would be a low-grade basal cell adenocarcinoma. Don't forget, basal cell carcinoma of the skin, right, is not the same thing as basal cell adenocarcinoma of the salivary gland. So basal cell carcinoma, not adeno, right, of the skin is a neoplasm of the basaloid cells of the epidermis. Basal cell adenocarcinoma is this glandular neoplasm of the parotid, different morphology, but both are called basaloid because of their very, very, very blue kind of features. Okay. All right, one very, very rare benign tumor is canalicular adenoma. Happens on the upper lip of older females, very, very rare. But if you're dealing with this anatomic subsite in this patient, this is what we sometimes think of histologically, benign. All right, I won't belabor this tumor. All right, let's move into the malignant, because this is the category box now of the tumors that are only malignant that do not have a benign counterpart. Okay, so once you're making a diagnosis of one of these tumors, you don't have to worry about it potentially being benign. It's always malignant. Now it's just a matter of, is it low or high grade? And again, we can break these down into a monomorphic single cell type versus a double, versus even in muco-ep, a triple cell type. And we'll see what that means momentarily. So muco-ep, as you know, as we mentioned, is the most common primary salivary malignancy, both in adults and children. So I never forget, kids can get salivary gland tumors, kids can get muco-ep. The three cell types we're going to see are squamoid, intermediate, and mucinous. The genetics in these are CRTC1, MAML2, or CRTC3. Very, very characteristic and seen in a very high percentage of muco-eps. Muco-eps on low power can be either solid or cystic. They can be circumscribed in the low grade forms. So still, just circumscription in this case will not make you benign. It will just make you a low grade malignancy, right? Because there is no benign muco-ep. Okay. But solid and cystic is going to come into play later in our grading of this tumor. All right, so the three cell types we need to see are the mucinous with this pale intracytoplasmic mucin, squamoid on the right, which almost starts to resemble squamous cell carcinoma with these very prominent cell borders with desmosomes, intercellular bridges, pink cytoplasm. And then in the middle, these sort of intermediate cells. Intermediate because they kind of neither are mucinous nor are they squamoid. They're sort of these just nondescript, very bland appearing cells. If a pathologist is not sure whether some intracytoplasmic material is mucin or not, we can use PAS with diastase. So periodic acid Schiff is a stain that will stain both mucin as well as glycogen. Diastase will digest out the glycogen, but will retain, but the mucin is resistant, okay? So here's how we can use a simple stain to help us determine, in this case on the top, true intracytoplasmic mucin of a mucoep versus just intracytoplasmic glycogen of, for example, a squamous cell carcinoma. Okay. Mucoep is challenging to grade. There are 4 published grading systems out there. 2 are quantitative, 2 are qualitative. All perform completely differently when you apply them to the same tumor. So what we found is that the AFIP system grades any given tumor lower than the other systems. And the Brandwein system grades tumors generally higher than the other systems, with Healy and Katabi sort of being in between. But in our institutional study of our patients, we found that when a tumor is graded as Brandwein high grade, it does have the potential for biologically high grade behavior. When a tumor is graded as Brandwein low to intermediate grade, these actually generally behave more like low grade. So I know you guys don't know what to do. No one knows what to do with it when I say this is intermediate grade. Well, do I treat it like a low or do I treat it like a high? Well, I think we've been pretty comfortable with if it scores intermediate in the Brandwein, it's probably okay to consider it relatively low grade, because in many studies, including ours, the low and intermediate grade tended to cluster together biologically. So we try to avoid intermediate grade and sort of push it into low or high. But always talk to your pathologist about what grading system are they using, because we know, we at least know how Brandwein works pretty well, with intermediate being more akin to low. Okay, hopefully that was clear. All right, our second most common carcinoma is going to be adenoid cystic. So most frequently in the major glands, this is going to be, of course, parotid. And then the second site we see this for minor glands is the palate. As you know, perineural invasion is very common, and these can be very aggressive. They can hide in the nerves, travel up the nerves. They can metastasize to visceral sites like lung, etc. Histologically, this is one of our tumors of 2 cell types. I'll show you that in a second. And genetically, these characteristically have MIB and FIB gene rearrangements. The characteristic morphologic pattern of adenoid cystic is this sieve-like, right, or Swiss cheese-like pattern, so-called cribiform, meaning these sort of punched out holes in the background of these islands of tumor cells. We grade adenoid cystic based on, is it more of a tubular pattern, is it more of a cribiform pattern, or is it more of a solid pattern? And here on the bottom left, just showing you perineural invasion, which is present in all histologic grades. All right, so what does this look like? The tubular pattern on the left is mostly consistent of these single tubules nested in stroma. When the tubules sort of coalesce, right, they then form these cribiform structures with these punched out Swiss cheese-like holes. And finally, on the right, when it becomes solid, you no longer see lumina or holes or spaces, you just see solidness of cells. The 2 cell types that we see in adenoid cystic are, of course, our epithelial and myoepithelial. And in the cribiform structures, the epithelial cells, as you can see here, are sort of sandwiched right between the myoepithelial cells on the edge. The myoepithelial cells on the edge here are highlighted by P63. The epithelial cells here and here are highlighted by c-KIT or CD117. So we use these stains sometimes to help us distinguish those 2 cell types in this carcinoma. What adenoid cystic can also do, as opposed to be, just grade 1, 2, 3, is actually further de-differentiate or transform into a very biologically high grade carcinoma. And so what does that look like? So our solid, just our classic solid adenoid cystic seen here on the left, with still round dark nuclei, but our even further transformed high-grade adenoid cystic or dedifferentiated adenoid cystic starts to gain larger open nuclei with prominent nucleoli, with tons of mitoses, with necrosis. And one would not be able to tell that this was adenoid cystic necessarily unless you have some component on the left that retains the characteristic morphology. All right, so these high-grade or dedifferentiated adenoid cystics behave even worse, high-grade malignancies. For pathologists, a histologic differential of adenoid cystic is polymorphous adenocarcinoma. This is most commonly seen on the palate, but the most common tumor in the palate is not polymorphous. On the palate, you're still generally dealing with a pleomorphic adenoma, with an adenoid cystic, and then thirdly, with polymorphous. Polymorphous architecturally can resemble adenoid cystic. It can be tubular, it can be cribiform, but the difference to a pathologist is that the nuclei are of a single type. We do not have epithelial myoepithelial cells. We only have a single cell type, and we have this more open vesicular chromatin. Sometimes we see mutations in the PRKD1 gene in these, so again, they are genetically different. Here's an overview of what a polymorphous adenocarcinoma might look like with heterogeneous architecture, with perineural invasion, but with vesicular nuclei. And immunohistochemically, we can prove on the top row that there are no myoepithelial cells, essentially by absence of immunohistochemical staining for P40. P40 would be positive in the basal cells of adenoid cystic and positive in the basal or myoepithelial cells of a pleomorphic adenoma. So this is very helpful for us in differential diagnosis. There is this variant of polymorphous that was proposed as sort of cribiform adenocarcinoma, which is generally seen in minor salivary glands outside of the palate, like the parapharyngeal space or the tongue. The morphology is similar. The genetics are similar, except for PRKD1 gene in these tends to be rearranged instead of mutated, significance of which I don't know, but just know that this exists, cribiform adenocarcinoma or cribiform variant of polymorphous adenocarcinoma. Okay, moving on to acinic cell. So as the name suggests, these resemble the serous acinar cells of the parotid. These tend to be very low grade, but can undergo high grade transformation. Recently, some genetic rearrangements have been discovered that are unique to acinic cell. So what do these look like? Well circumscribed, but the cells on the right, these very purple cells identically resemble the normal serous acinar cells of the salivary gland on the left, right? So you can see normal gland on the left has tubules, has fat, tumor, no tubules, no fat, right? Just cells. The other thing we can use PAS stain for, remember we used it to stain mucin. We can also use periodic acid shift for zymogen granules, right? So the zymogen granules are also resistant to diastase. Glycogen is sensitive, right? Glycogen will be digested out, but both mucin and zymogen granules will remain. The difference between mucin and zymogen granules is that the zymogen granules are little punctate, right? Dark purple things in the cytoplasm, whereas you saw before with the mucin, it was just one homogeneous kind of staining within the cell. So these punctate granules, we can confirm are zymogen granules. In the event of an unclear diagnosis, we can confirm acinic cell. Here's what high-grade acinic cell looks like. So I muted myself. Okay. On the right, you can still vaguely see the acini of the tumor. And then on the left, again, it's just this high-grade undifferentiated carcinoma with nucleoli, mitoses, necrosis, et cetera. Very similar to our other high-grade transformed salivary type of tumors. All right, moving on. So we're gonna reach a few tumors in the last 10 minutes or so that resemble carcinomas of the breast. So if you think about it, salivary gland and mammary gland are both similar. They both produce some kind of secretions. They both secrete out into the world. And so sometimes salivary tumors resemble breast tumors. So secretory carcinoma, formerly known as mammary analog secretory carcinoma, was described due to its resemblance to the same carcinoma of the breast. It is defined by its morphology as well as this ETV6 NTRK translocation. NTRK is now becoming important in tumor biology because it can be targeted, right? It can be targeted with these NTRK inhibitors. And so therefore, mostly for salivary gland, there is no targeted therapy with the exception of tumors that have NTRK gene rearrangements. Okay, such as this. So secretory carcinoma has varying morphology from cystic to papillary, but what is common is the secretion. So, right, the secretion can be this pale secretion into the lumen of these cystic spaces. It can be intracytoplasmic vacuoles that have yet to be secreted, and it is generally diffusely strongly positive for both S100 and mammoglobin, right? Mammoglobin being actually a marker of mamma, of breast, right? But mammoglobin is a unique marker in this tumor, and so we sometimes use it. But sounding like a broken record, just like most of these salivary tumors, this can also undergo high-grade transformation or so-called dedifferentiation, central necrosis, increasing mitoses, PNI, LVI, etc. So on the left, you have your low-grade area, and on the right, you have your high-grade secretory carcinomatous area. Our next tumor that resembles breast is salivary duct. So this actually resembles a high-grade DCIS of breast, occasionally with apocrine type of morphology. So once we make a diagnosis of salivary duct carcinoma, this is generally always considered high-grade. The importance here for treatment is these generally express androgen receptor in the nucleus very strongly and HER2 on the membrane with amplification in the cases that have very strong HER2 expression. Sometimes we'll get asked to do estrogen and progesterone receptor on salivary gland tumors, but I think this is phasing out because if this is truly a salivary gland carcinoma, it will not express estrogen and progesterone receptor to any significant degree. If it does express ER/PR, it is now a metastasis from the breast. So you're dealing with a whole nother bag. Just FYI, androgen and HER2, yes, definitely are positive in this tumor and definitely can be used for treatment purposes. ER/PR, no, it's a breast cancer. Okay. Here's an example of salivary duct showing that cribiforming type of morphology. In this case, you notice that it lacks the bluish material that we see in the cribiform spaces of adenoid cystic. It does sometimes have a little bit of central necrosis, and it does often have this very pink or apocrine or almost oncocytic-like morphology. Here's showing androgen receptor very strong in the nucleus and HER2 on the membrane. In case you didn't believe me before, this is what we look for. Okay, there is another carcinoma called intraductal carcinoma that, again, to a pathologist sort of resembles a low-grade DCIS or a low-grade atypical ductal hyperplasia of breast. Unlike salivary duct, these tend to mostly be confined to the ductal system. So here you can see intraductal growth bounded by a myoepithelial cell layer. Very rarely, these can be infiltrative. I'll show you what that looks like. So you can see on low power, this is almost a very cystic type of tumor with multiple cystic spaces. And when you apply a stain for a myoepithelial cell or a basal cell at the periphery, it is positive. And this is not a cell that is a part of the tumor. This is a cell that is a residual basal cell. Here, you can actually see it on H&E surrounding this duct. This is a residual basal cell of the pre-existing ductal system. So these grow within the duct, unlike salivary duct, which is kind of an interesting misnomer. It does not grow within the ductal system. So if you were to do a myoepithelial or a basal cell marker out here, it would essentially be negative in 99% of these lesions, 99% of the nests in a given lesion, okay? However, in this case, it is positive in 99% of the, or 100% of the nests in a given lesion, all right? So this is all considered in situ or intraductal spread of this carcinoma. Therefore, it is not necessarily always invasive. It is very low grade and can generally be excised. Hopefully that makes sense. Okay. Moving on to epithelial myoepithelial carcinoma. This is a very rare one, but this is characterized by, again, two cell types, as its name suggests, generally with the myoepithelial cells being of this very, very cytoplasmically clear phenotype. So you see the central duct core surrounded by this clear myoepithelial cell. Sometimes it resembles on low power the growth pattern. If you remember I showed you a pure myoepithelial carcinoma with this lobulated growth pattern with central necrosis in the middle. This low power growth pattern is very similar. However, on higher power, you will see that these sheets of myoepithelial cells with clear cytoplasm are sort of punctuated by these ducts, duct, right? This is now epithelial myoepithelial carcinoma as opposed to just pure myoepithelial carcinoma, okay? These do have mutations in the HRAS gene, so they're, again, genetically as well as morphologically unique. These also tend to be higher grade tumors with necrosis, mitoses, etc. Okay, moving on, we're almost done, to clear cell carcinoma. This used to be called hyalinizing clear cell carcinoma. Hyalinizing was dropped because it doesn't always have this beautiful stromal pink hyalinization. What it usually does have are these very, very, very clear cells. These are clear because of intracytoplasmic glycogen, not because of intracytoplasmic mucin, okay? These stain almost like a squamous cell carcinoma. But when we see something like this, that may be clear, stains like a squamous, but is in a salivary gland type of site, we will think about hyalinizing parentheses clear cell carcinoma. This is defined by EWSR ATF1 gene rearrangement. So again, genetically unique. However, this gene rearrangement is also present in so-called clear cell odontogenic carcinoma. Well, clear cell odontogenic carcinoma is morphologically and immunohistochemically and genetically identical to clear cell carcinoma of salivary gland. It just happens to occur intraosseously in the jaws, okay? So just one small point. All right. Sometimes in the salivary glands, we do get these squamous-like carcinomas. This so-called lymphoepithelioma-like carcinoma resembles our so-called non-keratinizing nasopharyngeal carcinomas. What this looks like are just syncytial aggregates of very high-grade cells that are positive for squamous markers with a background lymphoid stroma. So you may see a diagnosis of lymphoepithelioma-like carcinoma. This is basically a non-keratinizing squamous cell carcinoma. We always want to, in squamous cell carcinomas, we always want to exclude metastasis from nasopharynx or oropharynx, right? Or in the case of a keratinizing squamous cell carcinoma of the parotid gland, we want to exclude metastasis from a cutaneous primary. And in fact, these are metastases mostly from the skin. And you can prove that by demonstrating the characteristic ultraviolet signature mutations, which are C to T or CC to TT changes diffusely in the genome. So not a single gene mutation, just diffuse C to T changes, these dipyrimidine dimers. Squamous cell carcinomas of the parotid, again, just to repeat, are generally metastases. Excellent, it's 9 o'clock. So that's it. If you guys have any questions or comments, I will take them. Again, I will be happy to provide the recording for you to refer to if you choose. Thanks, everyone.